He began residency training in psychiatry at Kaiser Permanente in San Jose before coming to our program in July of 2023. What's really stood out for me since his arrival here is his growing interest in psychotherapy, of course, from a developmental perspective. This interest informed his construction of a series of medical student lectures titled Intro to Psychotherapy, a third-year medical student guide. You'll see his interest reflected in today's presentation, Trauma Expanding Our Focus. Please welcome Dr. Rana.
Okay, all right. Thank you, Dr. Pritchard, for the introduction. So I'm Dane Rana, for those who have not yet met me, and today I will be giving this talk on trauma and expanding our focus. If you can all hear me okay? Okay, good. So for the title slide even, I've selected this graphic that I think is demonstrative of what often gets thought of as trauma. The shadow in the background may represent overt physical trauma, but for purposes or reasons I hope will become clear throughout the course of this presentation, the young girl in the foreground too, I think we ought to consider as a potential symbol for the larger definition of trauma. This presentation, I think, is to be more thought-provoking than anything else, but in it, I hope that we will be able to understand a more historical view of the psychiatric definition of trauma, consider what this broader definition of clinically impactful trauma might be, and ways to incorporate screening for such traumas. I have no financial disclosures. But to start, I'll pose a question to the audience, which is, when you think of trauma, I wonder what is the most salient thing or types of things that come up for you. And for the sake of time, I'll probably just take one or two examples. So DV, certainly. Anything else? Neglect. And so neglect is more along towards the line of this definition I will discuss. Domestic abuse was actually a hard fought for kind of inclusion into trauma in this history that I will bring up. And so here is the current DSM-5 definition of what a traumatic event is. That's exposure to actual or threatened death, serious injury, or sexual violence, which can be directly experienced, witnessed, or learned about through a close loved one. Again, I'm going to advocate that we expand that definition, but still, I think it might be useful for us to take a look at how this specific definition came about and why other forms of trauma have been overlooked in it. So historically, trauma has been a part of human experience, even though there have been pathologic forms recognized early on. It's been seen in literary accounts. Here I have a picture of this statue of Gilgamesh from the Epic of Gilgamesh, who upon losing one of his close companions ends up being profoundly fearful of his own mortality. Trauma shows up even in, let's catch up, the Bible, where in the book of Deuteronomy, there's references of military leaders calling for soldiers to leave the army so that they don't infect their other soldiers with panic. There have been historical accounts of trauma as well. So most famously, there's Herodotus, who talks about mental illness in the battlefield at the Battle of Marathon. And so pictured here, I have Phidippides, the marathon runner after which the marathon race is named, who died immediately after, discussing the victory of the Athenians at the Battle of Marathon. And as we move forward, I'll be focusing now much on this modern history of diagnosable trauma, which is also colored by combat. So to start, we'll take a look at these formal definitions, beginning with World War I, with the terms battle hypnosis and shell shock. These phenomena were marked by sudden muteness or deafness when others were noted to see their maimed or dead comrades on the battlefield. In World War II, much of the same phenomenon was described, except now under the terms battle exhaustion, combat stress reaction, or war neurosis. It wasn't until 1952, with the first release of the DSM, that there was this category termed gross stress reaction. This was described as an extreme response to an extreme stressor, be it physical or emotional, in a subject with a normal personality. Here too, though, the stressors that are listed that might cause symptoms were combat or civilian catastrophe, and the examples they give were fires, earthquakes, or explosions as causes. When the DSM-2 came out in 1968, it was during a relative period of peace, understanding fully that this does occur in the Cold War era, but overt military action from the US in Vietnam didn't take place until the 60s. So maybe understandably, in the lack of overt military action, the gross stress reaction diagnosis from DSM-1 was dropped. Instead, it was captured in this diagnosis called transient situational disorder and adjustment to reaction to life. But the stressors that caused this diagnosis were quite limited and limited to 3 examples. Those being unwanted pregnancy with suicidal thoughts, fear linked to military combat, and Ganser syndrome. And as a reminder for those unfamiliar, Ganser syndrome is a syndrome marked often by approximate incorrect answers. An example would be an individual being asked, how many legs does a horse have? And they saying 5. Finally, in 1980, the definition of what we've come to know as PTSD arrived. And kind of to Guggen's point earlier, this is largely a combined effort of advocacy from many groups, including war veterans, feminist movements to include sexual trauma as part of the definition of trauma, but also as part of Holocaust survivors, amongst others. So PTSD made its way into the DSM-3 at this time as a distinct disorder, where it's remained since then largely unchanged in definition. So I put forth this timeline and history mostly to be demonstrative of the early and strong association of trauma with combat. What I think it lacks, however, is a mention of other events that I'm advocating we consider as trauma. And so for that reason, I consider the DSM inadequate to the task of defining trauma. Its narrower definition of trauma leads to exclusion of acts that both may occur more frequently, but also still contribute to PTSD and the symptomatology of other psychiatric disorders. This current definition focuses on acts of commission, so the presence of overt negative acts, but it excludes the absence of developmentally normative acts of omission. And it might not actually represent what we're treating in the clinic. If we look at the prevalence of DSM-defined PTSD, for instance, there is a prevalence of 6.1 to 8.3% in adults, 5.0 to 8.1% in adolescents. Yet, if we review the frequency of common types of abuse, it suggests development as a place that we can look for this more broad definition of trauma. And that's evidenced here by the prevalence of emotional abuse of 36.3% in children worldwide. I've referenced the case of Benjamin Button here because, in my perspective, trauma has been defined from a largely adult phenomena of war or catastrophe. But I feel like we have to look earlier now in development, sort of in reverse, to find a more fitting interpretation. And so while I will be talking about trauma from primarily a developmental perspective, I do think it's noteworthy to report that there are equally important forms of trauma that are beyond the scope of my presentation, but these might include racial, historical, or intergenerational traumas. So what then is the theme of this type of trauma that I think gives the most clinically significant account for what we're trying to look at? I've put up a quote here from D.W. Winnicott, the influential analyst, which is, "It is when things do not go well that the infant becomes aware, not of the failure of maternal care, but of the results, whatever they may be, of that failure." So even here from Winnicott, we get hints of what this type of good enough caregiving can be. And when care is given in a good enough manner, development proceeds without issue, much like the otter mom here can leave her pup wrapped up in kelp, forage for food, but come back in a way that is good enough for her pup. And while I can't speak for the psyche of otters, it's this type of consistent, good enough caregiving that leads to normative development in humans. And when those things are not met repeatedly, that is what aligns with what I'm going to suggest we consider as a traumatic event. So in preparation for this talk, I came up upon this framework of psychological maltreatment, which I think fits the bill for this larger definition of trauma. It's also known as emotional maltreatment, psychological or emotional abuse and neglect, as well as mental injury, and is defined as any repeated pattern or extreme incident of caretaker behavior that thwarts the child's basic psychological needs and conveys a child as worthless, defective, damaged goods, unloved, unwanted, endangered, primarily useful in meeting another's needs, and or expendable. It's a mouthful. And still, you can see how this definition might apply to a broad range of maltreatment that is likely experienced by many, likely many even in this room. And still, I will make the case for how these traumas can have real psychological impact on our patients. Itself, PM exists under the larger umbrella of childhood maltreatment, or CM. That includes all forms of interpersonal violence that are perpetrated by caregivers unto their children. This definition of PM comes from the American Professional Society on the Abuse of Children, or APSAC, and it also notes that most PM is chronic, regular, and embedded in the child's daily existence. And so that this type of trauma is pervasive and not of the acute incident or combat-related type that we've been discussing, I think that speaks to how potentially damaging this type of trauma can be because of its pervasion. The statistics on this prevalence of type of trauma, again, align with those on a previous slide, which is 26 to 32% of the population, depending on the study. Beyond this general definition of trauma, the APSAC provides 6 different forms of psychological maltreatment, which I'm going to go through briefly just to see how you could identify these different forms clinically. So to begin with, there's spurning. That's the verbal and nonverbal hostile rejecting or degradation of a child. Terrorizing, behavior that threatens or is likely to physically harm the child or place them or their loved ones or objects in danger. Exploiting or corrupting is any behavior that encourages the child to develop inappropriate behaviors. You can consider parentification is a common theme I see amongst my patients, where as a child, they're made to take on so much more responsibility than ought to be due to any child. The corruption piece can be a father figure asking their son to bully some other folks on the playground because they think it shows some type of superiority if you are physically able to overcome somebody else. Denying emotional responsiveness is another type, which is ignoring the child's need to interact, failing to express positive affect for the child, or really not showing emotions in interacting with a child. Isolation, which is denying the child's opportunities for interacting with peers or adults in an appropriate way, and mental health, medical, and educational neglect. I've highlighted this emotional unresponsiveness piece here because, in my view, this is one of the most commonly overlooked forms of psychological maltreatment. I'm thinking now of several patients I have, one of whom has told me they didn't have bad parents. They just didn't talk about the negative emotions. And so the reason that I think that is so striking is one of the biggest pieces of our work together now is focusing on how they can allow themselves to feel negative affect, to disagree with people at work, which has been very significantly impactful on their own lives negatively. Another patient I've had who was told that he would be ignored if he would act out or voice any displeasure with what his parents was talking about. Again, a large part of our work is to get around the self-critical piece that comes up for him when he feels the same types of acting out emotions that he's been forced to disavow as a child. I think for time, I'll skip the slide, but it talks about emotional unresponsiveness because of how overlooked I think it can be, but how it may look across the developmental spectrum. If we have time, I may come back to this. So I've talked about a broader definition of what I believe should be considered trauma. But this definition and these types of traumas I've brought up, do they actually have any clinical impact? I've listed a few studies that suggest they do. So there's Vashin et al. 2015. The goal of this study, and this is out of JAMA Psychiatry, was to determine whether the different forms of childhood maltreatment, meaning physical versus psychological versus sexual abuse, have equivalent effects downstream of one another with respect to clinical symptomatology. It was striking because this particular study had a pretty sizable N of around 2,200, and they investigated over a week-long summer camp these 2,200 children over the course of 26 years. So these children would rotate year after year through a summer camp, and there would be measures of self-report, peer report, as well as counselor report on what types of symptoms these children were experiencing. What the study found was that the types of CM were in fact equivalent. Psychological maltreatment was equivalent to physical as well as sexual abuse. Next, and I think that sets the foundation for some of these other studies that extends that impact of psychological maltreatment. There's Valencia et al., 2024, out of the Journal of Psychiatric Research. The goal of this study was to examine the default mode network connectivity across individuals with a history of childhood maltreatment that spanned 3 psychiatric disorders. Historically, impairments in deactivation of the default mode have been evidenced in mental disorders, including major depressive disorder, PTSD, and cognitive control tasks. What this study found was that there's a decreasing negative correlation of connectivity between the default mode and the visual networks. And this is postulated to represent a failure to suppress negative internal thoughts, but may also be looked upon as potential reemergence of re-experiencing symptoms of PTSD. Possibly most striking to me on this slide was Korgankar et al. 2023. The goal of this study was to identify a functional neural connectome signature of childhood maltreatment. Essentially, it's Dr. Taylor's looking for a biomarker of psychiatric disease. And so this study, participants, sample size of around 650, they underwent 5 fMRI tasks, and they were also scaled to see what types of childhood maltreatment they underwent. What the study did find actually that there was a connectome signature of higher connectivity within and between networks associated with depression and also with a history of childhood maltreatment. That this specific signature was specific to childhood maltreatment and does predispose any individual to more psychiatric diagnoses later on in life. Lastly, on this slide, I have Dube et al. 2001 out of JAMA. The goal of this study was to examine the relationship between the risk of suicide attempts and adverse childhood events, or ACEs. What they found was that emotional abuse, psychological maltreatment, had the highest odds ratio amongst ACEs for lifetime attempted suicide. And that's an odds ratio of 5.0, meaning if a child had experienced emotional abuse, they had a 5.0 times odds of having a suicide attempt in their lifetime. Now, this is a very busy slide. I think more than anything, this is from the Vashon et al. 2015 study. Its intent is to be more illustrative of the wide-ranging effects of psychological maltreatment. I don't expect you to be able to read these tables in their entirety, but I'll summarize it for you, which is there is more profound impact of psychological maltreatment when experienced with increasing variety, frequency, and severity, and that this impact spans both internalizing and externalizing symptomatology, the basis for many personality disorders as well as other psychopathology. I've highlighted in these red boxes the various types of symptom clusters that were looked at in this study, and they range the full gamut: depression, withdrawal, somatic symptoms, anxiety, neuroticism, rule breaking, aggression, disruptive behavior, and fighting. And so this, to me, was particularly striking because these are, with the exception of psychosis, pretty much everything we treat in psychiatry. And so much of this can be potentially pinned on psychological maltreatment, knowing that there is a signature of symptomatology that is linked to this history of childhood maltreatment. I think this is a good reminder that because these symptoms are so widely present and amongst various different DSM diagnostic categories, that we ought to look at our patients from a more developmental perspective rather than just treating their symptoms. Before I move on to diagnostic implications of what I've just presented, I'd like to include a nod to this phenomenon of resilience in the study of traumatology, which is really the ability in some individuals to be exposed to trauma, but not have any of the symptoms that you see on this slide. The mechanisms by which resilience occur might be out of the scope of this presentation, but because it was interesting, I briefly looked at the literature review. And what is suggested is that secure attachment to competent caregivers and the ability to accurately perceive safety versus threat are key in developing or having resilience against traumatic events. Now, as far as diagnostic implications go, I think then it's really important that we consider the following, particularly at an initial evaluation of a patient or when encountering treatment resistance. Practical tools to consider then might be looking at even the Adverse Childhood Experience Questionnaire, whose line items provide a good starting point in investigating psychological maltreatment. And I'll leave that questionnaire up at the end of my presentation so that you could take a look. But you can also consider other screening questions for PM. I've devised a couple of these on my own and used them in evaluations, and I've found them to be helpful. But some of these questions might include, how were difficult emotions dealt with growing up? How would you describe mom or dad or your caregivers growing up? Did you feel that they met your physical or emotional needs appropriately and adequately? And who are you closest to or felt that you could turn to as a kid? In asking these questions, you are likely to get multiple benefits. Firstly, you're probably going to get a lot of different types of PM just on these screens. But also, you're likely to ask questions that your patient has not been asked before. And in so doing, you get a better understanding of them and provides that texture to their case. While understanding your patient a bit more, you now have developmental treatment targets should you want to pursue psychotherapeutic interventions. And so the key takeaways I hope from this presentation, really this is a don't miss the forest for the trees moment. And the trees currently are our current definition of trauma. And that while it is historically linked to combat and military linked contexts, it is understandably and unfortunately narrow. The forest then includes all forms of trauma, including PM, but also the other forms of trauma alluded to earlier. Again, the racial, historical, and intergenerational forms. Lastly, what I hope you take away is that these forms of traumas can be relatively practically screened for using the questions and even the ACE questionnaire I talked about previously. And I'll just thank you all for your time and attention. A special mention to Drs. Pritchard and Curry for your mentorship and resources in this project. I have my resources here, and I'll leave up the ACE questionnaire if there's time for questions.